Assalamu alaikum, everyone. My name is Dr. Murtada Khabouri. I'm one of the adult hematologists at Sultan Qaboos University Hospital, Muscat, Oman. It is my pleasure to be part of this conference. I would first like to thank the organizers and the scientific committee for their invitation. My topic today will be about updates of anemia of chronic disease. Now, there has not been much of updates in the last few years about anemia of chronic disease, except maybe in the pathophysiology. I'll try to highlight the updates and maybe focus on how we approach anemia of chronic disease. The outline of my presentation would include the following. First, maybe 2 slides with the general approach to anemia. And then we will dive into the pathogenesis of anemia of chronic disease, and then very briefly on the epidemiology, then diagnostic approach, and then the principles of management. Now, we start with the general approach to anemia. And we start with the general comments about approach to anemia. Now, the first comment is that most patients presenting in the primary healthcare usually with anemia usually have a single etiology. So that makes it easier to diagnose. So let's say they have either B12 deficiency or they have iron deficiency anemia, but it's usually one etiology. Now, the most common etiology that these patients have, those presenting with anemia, is iron deficiency anemia. That is in the primary healthcare setting. Now, if you go to like secondary care hospitals, then maybe anemia of chronic disease becomes more than the primary healthcare. So, but still the commonest would be iron deficiency anemia, and then the anemia of chronic disease. So the topic that we're describing now is a common presentation that you would see in your settings. Now, one clue to that it is more than a single etiology is that when you start treating, so let's say you suspected iron deficiency anemia, you started with iron, the patient is not responding as expected. So there maybe you could suspect that there may be a combined or another etiology beside iron deficiency anemia. And this is also true for B12. Now, the approach to anemia would depend on the 3, something called MCV, mean corpuscular volume, which is the size of the red blood cells. And this is a very important differentiating factor in anemia. And it's important, it's incorporated in most of the approaches to anemia. The second is RDW, red cell distribution width. And what it essentially means, it means the variation in the size. So let's say if you take like 1 million red blood cells and you do the distribution, you see a little bit of a distribution. Not all of them would be the classical size of the red blood cells, but there would be a distribution. That distribution is RDW. Now, if the distribution is 0, then everything would be like exactly the same. But there may be some variation. And the distribution is around 15 or so. Now, when you have some anemias, that distribution would increase. And that may be a hint that the anemia is due to a specific etiology. So this is another important factor in differentiating etiologies of anemia, although most of its use is in microcytic anemia that we would discuss. The third important differentiating factor is the reticulocyte count. And reticulocyte count is the young red blood cells just came from the bone marrow. And their size, their amount is a reflection of the bone marrow activity. So there are anemias that we call hypoproliferative anemias that is characterized by low production of the red blood cells. For example, iron deficiency anemia. So with iron deficiency anemia, your production of the red blood cells would be lower than you expect for the degree of the anemia. Hence, your reticulocyte count would be lower than expected or inappropriately, sometimes inappropriately normal. These are the three important differentiating factors that you should think of when you approach to anemia. Now, based on the MCV, anemias are usually classified into three: low MCV, microcytic anemia; normal MCV, normocytic anemia; and high MCV, macrocytic anemia. And the MCV is directly calculated or estimated from the automated CBC machine. I mean, this is even before you look at the blood film. So some people use MCHC, but one of the commonest differentiating factors is the MCV. Most of the textbook would refer to the MCV. Now, if you look at it, there are certain etiologies for each of these anemias. For the microcytic anemia, classically is the iron deficiency anemia, thalassemia, and sometimes it's anemia of chronic disease, the anemia that we are interested in today. But usually the anemia of chronic disease is normocytic anemia. So it's also listed under normal MCV anemias. So for the normal MCV anemias, normocytic anemias, the type of anemias include hemolytic anemias, and most of the hemolytic anemias would have normocytic anemia, anemia of chronic disease, and other types of anemias. And the macrocytic anemia, it's classically B12 and folate deficiency, and there is a characteristic appearance of the neutrophils and on the bone marrow, and we call it megaloblastic anemia. So megaloblastic anemia is a type of macrocytic anemia. And there are other macrocytic anemias that are non-megaloblastic. So back to the focus of today's presentation, anemia of chronic disease, and it's usually normocytic anemias. Now, let's go for our second part. Let's go to the pathogenesis of anemia of chronic disease. So anemia of chronic disease used to be called anemia of inflammation or anemia of chronic inflammation. So inflammation is like a very important component of these anemias. And previously people would equate anemia of chronic disease to anemia of inflammation. However, now we know that there are other conditions, other chronic conditions that are associated with anemia of chronic disease and not classically associated with inflammation. Diabetes, heart failure, critical illness. Critical illness is acute illness. So these conditions can also produce anemia of chronic disease, not the classical chronic inflammation that has been previously associated with chronic disease. Now, anemia of chronic disease is a type of defense strategy. In evolution, it is considered as defense strategy. And if you look at the characteristics of the anemia of chronic disease, it has two major characteristics. One is that the circulating iron is low, so low circulating iron. But when you look at the storage of iron is usually normal or high. Now, when you have an invading pathogen, this is what you want, right? You don't want iron to support the growth and the invasion of that pathogen, but you want to keep it in your store. This is what happens in anemia of chronic disease. The iron is low in the circulation, but in the storage, it is high. Now, the hallmark of anemia of chronic disease, we go back to the inflammation, cytokines, and specifically IL-1, IL-6, and tumor necrosis factor. Now, this figure illustrates the different parts of the etiologies of anemia of chronic disease. So when you have high cytokines, inflammation, you increase the hepsidine, which is a major regulator of iron metabolism in the body. With also increased cytokines, inflammation, you decrease the erythropoietin production in the kidneys. And again, with the high inflammation, high cytokines, you try to suppress your bone marrow. So the RBC production is suppressed. Not just that, the acceleration of the red blood cell destruction is also increased. So the survival of red blood cells is also decreased. And these three different ways are all contribute to the anemia of chronic disease. Now let's dive to the hepcidine, which is what has been recently, in the last few years, not that recent, in the last few years, been described in anemia of chronic disease. As we said, hepcidine is a major regulator of iron metabolism. So what happens? It's produced in the liver, and it regulates an iron transport receptor called ferroportin, the FPN. So the action of hepcidine on this transport is to inhibit it. When you have increased hepcidine, that transport receptor is suppressed. And that receptor is available first in the gut. And so when you have high hepcidine, the iron absorption from the gut is suppressed. So that's one element. The second part is the utilization of iron from the liver and the reticuloendothelial system. So here where the iron is stored, to release it, the iron would have to go through the ferroportin. And when you have increased hepcidine, the utilization of iron, the excretion, if you want to say it, excretion of iron from the liver into the circulation, the release of iron is decreased. And this is also true for the reticuloendothelial system. Now, you need the iron to be in the plasma to be able to be transported for the erythropoiesis. And when you have high cytokines and you have high hepcidine, you have low iron, plasma iron, low circulatory iron, and hence the utilization of iron in the erythropoiesis is decreased. Now, logically, if you wanted to treat iron anemia of chronic disease, you should target hepcidine. And this is one of the novel approaches that we would discuss later. Now, the epidemiology of anemia of chronic disease. It is mostly seen in inflammatory states. Now, I've listed a number of inflammatory states, either the classical inflammation or the non-classical inflammation. A classical inflammation is the systemic inflammatory disorders that we all know. Infection also is inflammatory condition. Let's say COVID. Now, anemia in COVID has been well described, and the anemia of chronic disease is one of the mechanisms by which anemia is produced in COVID. Malignancies, other chronic disorders, as we said, where the inflammation is not as apparent, like diabetes. Aging apparently is also an inflammatory condition that has been associated with anemia of chronic disease, and also kidney diseases. Although the etiologies in aging and kidney diseases are slightly different, although anemia of chronic disease operates in both conditions. Now, the presentation of anemia of chronic disease is usually associated with the underlying chronic disease. So if you have, let's say, diabetes, your presentation would be more of a diabetes, and anemia would be coincidentally found in your CBC. This is also true for the other inflammatory conditions. Or if someone does not have an apparent inflammatory disorder, then a routine CBC may show anemia of chronic disease. Now, when you look at the CBC from the automated machine, you would find mild anemia. So when you see a severe anemia, like a hemoglobin of 6 or 5, it is unlikely related to anemia of chronic disease. Although anemia of chronic disease could be partly an etiology there, but there must be another etiology giving you severe degree of anemia. Classically, it is mild anemia. Now, typically, it is normocytic, normochromic anemia, as we discussed before, and you can see that either from the blood film or from the automated CBC machine with the MCV and MCH. And when you look at the reticulocyte count, now, if you think about it, anemia of chronic disease, there is low circulatory iron. Hence, the production of the bone marrow, the erythropoiesis from the bone marrow will be suppressed. So it will be classified under hypoproliferative anemias, i.e. your reticulocyte would be low or inappropriately normal for the degree of anemia. Usually, it is a diagnosis of exclusion. So you look at the other etiologies, normocytic anemias, other types of normocytic anemias, and where you don't see a clear etiology and you see a clear inflammatory condition or a chronic disorder, then you say it's maybe anemia of chronic disease. Now, one of the classical things that you may order is the iron studies. And the iron studies are classical here. So when you look at it between iron deficiency anemia and anemia of chronic disease, so serum iron would be low in both. However, if you look at the ferritin would be decreased in iron deficiency anemia, classically low ferritin, but in anemia of chronic disease, it may be either normal or high, and classically it is increased if there is a clear inflammation. Now, if you look at the transferrin, or the other name is total iron binding capacity, TIBC, classically the iron deficiency anemia, because is increased. Here in iron deficiency anemia, you want more, let's say, vehicles to transport your iron, right? So that you could utilize and get iron as much as possible from the gut. Hence, it is usually increased. Where in anemia of chronic disease, this is usually suppressed. So that may be a differentiating element between iron deficiency anemia and anemia of chronic disease. Now, transferrin saturation is classically low in or decreased in iron deficiency anemia, and it is not uncommonly normal in anemia of chronic disease. Now, if you look at the novel ways of diagnosis, although this is not available in most of our standard labs, I'll just highlight two things: the soluble transferrin receptor, and here the concept is similar to the TIBC, the transferrin, where it is increased in iron deficiency anemia, and it's usually normal in anemia of chronic disease, if you have it available. If you have serum hepsidine, that would be the best to differentiate iron deficiency anemia or anemia of chronic disease. Unfortunately, this is not available in most labs. So it's classically decreased in anemia of chronic disease, in iron deficiency anemia, and increase in anemia of chronic disease. The final part of my presentation is the management. So here, the principle: treat the primary cause. Otherwise, your anemia of chronic disease will continue. The second is avoid blood transfusion in chronic illnesses, because even if you transfuse, the transfusion would be good for only a few weeks, then the patient would be anemic. So you don't target the hemoglobin level, you target symptoms. The third principle: look for other causes. The fourth principle: target symptoms, because as we will discuss, the erythropoietin is one of the treatment you use. Here, you don't try to get hemoglobin very high, because it has been associated with complications. Now, when you look at the management, the conventional ways now is the supportive transfusion. And here it goes back to the principle of minimizing the number of transfusions that the patients need. But two things that are important in management of anemia chronic disease is the erythropoiesis stimulating agents. And here we have epoetin, EPREX, which is usually given in 20,000 units. So this is much more than what is given in anemia in chronic dialysis, to 60,000, or dalbipoetin. So dalbipoetin, there are different ways of prescribing it. The way actually that we do is to give it weekly, not every 3 weeks. So we give 2.25 microgram per kilo to start with, and then we increase it till 4.5 microgram per kilo. We started when the hemoglobin is below 11, but we stop when it is over 12 because of the other complications. Now, if you look at that pathophysiology of anemia of chronic disease, you can target different pathways. And one of the pathways is the inflammation. So here, classically, if you target any part of this inflammation, the IL-6, the JAK-STAT pathways, SMAT pathways, now in theory, that should help your anemia of chronic disease. And this is about the novel therapies to anemia of chronic disease. Now, one of the novel therapies is the direct hepcidine antagonist. Unfortunately, we've been hearing about studies to inhibit hepcidine for some time now, and no major success that maybe would allow it to come to the clinical practice soon. And most of the other agents are targeting the inflammation, but they're still really early in the management of anemia of chronic disease. However, some of those agents are important in targeting the inflammation, the primary disease. So in summary, anemia of chronic disease is the second commonest anemia after iron deficiency anemia associated with inflammation and other chronic conditions. Cytokines increase hepcidine, which traps iron in the reticular endothelial system. And this is making anemia of chronic disease characterized by low circulating iron and normal or high iron storage. The principles of management include treat underlying cause, use blood transfusion sparingly, and consider erythropoietin stimulating agents to improve symptoms. This is the end of my presentation. And again, I would like to thank the scientific committee for the organization and the invitation, and the audience for the listening. Thank you very much.